frustrating. And it's being recorded. And so disruptive to us and so many lives. It's amazing. But we're thrilled to be able to continue Inspirational Women programs via Zoom. Thank heavens some of us are tired of Zoom, but it's been wonderful, right? And today's topic is so relevant and so unfortunately so, but we really need to open our eyes and ears to the issues. And that's why we're so grateful to Rachel and Ruth for sharing their expertise for us. And I also want to thank Mary for arranging this program. Thank you, Mary. And now Mary will introduce our two presenters, Rachel and Ruth.
Thank you, Chris. Thanks. Welcome. So nice to see such a great group here. Chris and I very much enjoy planning these Inspirational Women's meetings, and we always welcome your ideas for both topics and speakers. And of course, we'll continue to do so. In recent months, however, we've come up with an excellent plan for identifying compelling speakers for our meetings. After a great deal of thought, we've identified two productive categories to draw from. Sometimes we reach into our first group, as we did to find Karen Milbourne, the senior curator at the National Museum of African Art, who many of you will remember gave us a fascinating talk in April. And Karen's mom and Chris are good friends. So the first category is our friends' children. For today's speaker, I come through the second category, our children's friends. Rachel Rempell and my daughter were classmates at Penn Charter, and we are thrilled to have Rachel and her friend and colleague, Dr. Ruth Abaya, here with us today. Dr. Rempell is an attending physician in the emergency department at Children's Hospital of Philadelphia and associate professor of clinical pediatrics at the Perelman School of Medicine at the University of Pennsylvania. Dr. Abaya is also an attending physician in the emergency department at CHOP and a practice-based scholar at CHOP Center for Violence Prevention. Dr. Abaya is also the program manager for the Injury Prevention Program at the Philadelphia Department of Health. Doctors Rempell and Abaya will describe the impact of poverty and the pandemic as seen from the emergency department at CHOP. First, Dr. Rempell will focus on the behavioral health crisis, and Dr. Abaya will then describe gun violence and the myriad of negative effects it has on our community. So I'm so happy to be turning this over to Rachel, who I've known for 30 years, but she's not Rachel Gallagher. Now she's Dr. Rachel Rempell. Thank you.
Thanks so much, Mary. It's pretty, I guess I am really old if we've known one another for 30 years. I think it's official. I'm really happy to be here with all of you. It's exciting to sort of talk about in the emergency department at CHOP, because it's something that we just enjoy through our experiences, most notably sort of what things have looked like during the pandemic. And in particular, what I'm hoping to do is just I'm going to sort of speak really briefly, because Ruth is really the star of this show. I'm totally inspired and in awe of her as my peer. But I wanted to sort of provide a little bit of context around sort of the background of our work in the emergency department and sort of how it really frames sort of work that people like Ruth go on to do, because what we do day in and day out in the ER is sort of bear witness to a lot of things. And then it drives many of our colleagues to go off and really have impactful change in the community in response to what we're seeing. And the pandemic really has, just as for many of us on so many levels, has just dramatically magnified anything that we were seeing subtleties of pre-March 2020. So in terms of just in general, our environment, I have to say I love my job. I think day in, day out work is extremely invigorating, exciting. People often comment on the terrible shifts, and I think it speaks to how exciting the job is that I truly don't mind going in at midnight on whatever night it might be. My social life used to be far more exciting when Mary knew me, and now on a Friday night at midnight I head on into the CHOP ER, and I love it, but I will say it is not without really being aware of the fact that the job that we're doing is made dramatically more complex and more compelling because we're doing it in the largest, poorest city in the country. And having worked in other cities, it is night and day, the type of job that we're doing as compared to colleagues even in other areas of the country, because the environment in which we are working, and specifically West Philly, but really greater Philadelphia at large, is a city that has really far more negative social determinants of health than many other environments. So not only are we working within Philadelphia, a city I grew up in and absolutely love, but it is a city with tremendous challenges. And we're working with the pediatric population, and that's going to be the population that experiences these challenges most severely. So we see this is the picture when they sort of wanted to give a pictorial representation of the 100,000 people who had passed away from COVID. This was sort of the photo that had gone sort of viral in a lot of the press. And this is just to note, we see about 100,000 patients a year in the CHOP emergency department. So we're seeing a tremendous number of patients every year for a wide array of complaints. And really our day in, day out is just quite a myriad of things. I think one of the reasons I enjoy the job so much is that I'm just by nature incredibly nosy. And so you just get to be in everyone's business of whatever they're coming in for. And often what we're doing is minor, thankfully, and not everything is a crisis, but we are seeing people with significant chronic illnesses, asthma being a significant, significant prominent one, but there's a wide array of other things. We are, I will say, sadly, seeing quite a bit of, child abuses coming our way. We have patients who were born extremely premature and they have lifelong sequelae of that challenging birth. And then we have more severe disease processes like cancer. And then in the mix of all this, and it's not extremely common because fortunately pediatrics is not a group that is having extremely high rates of major traumatic injuries, but we certainly see them, and they are certainly something that impact our work environment in a profound way. And so thinking about the work that Ruth is doing, I mean, these are, thankfully, are they day in, day out events? No, but when they do occur, do they impact the entire group working there that day? Yes. Do they carry it with them home? Yes. And is it something that really, is it a much higher rate in Philadelphia than elsewhere? Definitely. So, and then we come back out after being in taking care of a patient with a major traumatic injury, and we're back out sort of, taking care of the broken arm. So we do the full gamut, but we're, it's a group that we really do sort of love the work. And then COVID came, and, it really sort of, it will definitely be a defining moment in so many ways, but it has completely upended a lot of the way that our emergency department, which is a pretty well-oiled machine, functioned. And not the least of which is that it just changed what our patients were suffering from. And ironically, the beginning of COVID was not a pediatric disease. It absolutely wasn't. We were afraid of it. We very quickly realized that kids either weren't getting it or we couldn't even tell they had it because they really weren't getting sick from it. And then it didn't take long for us to actually settle in and say, the real crisis here is not COVID. It's not like the grandparents who were being intubated and dying from COVID. It was actually that the children in our city who had already had significant challenges with behavioral health needs were in a unprecedented behavioral health crisis. And after the onset of the pandemic, the increase in emergency department behavioral health visits was up nearly a quarter or up to 30%, depending upon the specific age demographic that you're looking at. And, to think about that degree of increase and to know that, taking care of a patient with a behavioral health complaint is not like putting sutures on a forearm. It is a involved, multifaceted, profoundly impactful visit for a family, that is a huge change in terms of the care environment of the emergency department. And so that was what we really quickly pivoted to realize was really the thing that we actually should be focusing on. We had talked a lot about masks and N95, and at some point I was like, enough with that. This is actually the crisis that's in front of us that we need to address. So, just to give you a little quick sense of sort of what it looks like, because I think it's something that really most people don't necessarily realize how much of this we're doing in the emergency department and what sort of scope of things we're seeing and how we're trying to handle them. There are crisis resource centers across the region that are sort of built and structured to be independent centers where behavioral health complaints can be cared for. But the reality is that the majority of these patients end up coming into the emergency department and aren't necessarily cared for in those crisis resource centers. And in the pediatric population, that behavioral health crisis can be very heterogeneous. It can be a child who's just coming in with significant aggression. A school is noticing that they were causing multiple fights in the playground that needs to be evaluated. They're unsafe to others. Can be profound depression. Could go on and on. It could be many hours in and of itself talking about social media, but alarming social media posts with content that is very either concerning for that child's health or someone else's safety, definitely sometimes prompts sort of concern that there's a behavioral health crisis that needs evaluation, or a suicide attempt. So ingestion of medications in the home, a variety of articulation of suicidal thoughts, any of those things, and those are all coming into us. So we really try our best to have a multidisciplinary team that really tries to envelop these families and look at how we can help them. But as you can imagine, you're meeting these families for the first time. So even your most skilled practitioners, you have very little context really, and you try and get in deep right away, but it's a challenging thing to do. And so we think about potential medical etiologies. You never want to miss something that's actually a representation of a non-psychiatric illness. We have our psychiatrists who we're thankfully really close partners with. And then we have our social workers who really help us to ensure that we're thinking about the 360-degree view of this family and their child in crisis. And then we think about what disposition is really the best for them. Is it outpatient? Is it a partial hospitalization? Is it inpatient? And the other reality is that this is just the tip of the iceberg. Like, these families are just coming in, these poor kids are coming in just with this, but this is not something unlike the broken arm that we fix and they go home and it's better. This is weeks, months, we know, of trying to heal this. And we know that these patients are very likely to have recidivism higher than other patient populations. There's a severe shortage of providers for even a family. Often they'll come in and say, I didn't want to come in, but I've been trying to call therapists for 6 months and I can't find anyone who takes my insurance. It's not. Or there are very nice systems called partial hospitalizations, which are a nice middle road. A kid can go there, not still stay at home, and then be going there 5 days a week for really intensive therapy, but they're limited in availability. And then inpatient hospitalization is the other option. So the average wait for inpatient hospitalization is upwards of 60 hours. So a family could come in, the poor child is in crisis, they've made a suicide attempt, we've stabilized them. And then in that moment of stress, they then are in a limbo where they're awaiting an inpatient psychiatric hospital placement. So such a stressful moment, but there's no ability to provide active treatment because they're awaiting that placement because of the bed availability. And so then they're often spending several days with us where we're sort of temporizing things. So it's we're trying our best, but it's an imperfect situation at best. And specific to the post-pandemic era, we're just seeing that these patients are have tremendous needs and are a very high portion of our resources. So they are going to be an emergency department fixture for quite some time until we're able to find a different sort of infrastructure for them. They account for only 16% of sort of all of our patients, but they're up to almost a quarter of our visits. And we know that they are far more likely to have multiple visits than other patients. So they're not just coming, but they're coming frequently. And you can see that while a lot of people have a single visit, they're going to come 2, 3, 4 times within a 2-year period, which is, as you can imagine, if you think about the threshold to go to an ER, this is a family that's in crisis and is in sustained crisis for quite some time. And then on the inpatient side, our hospitals really struggle because these patients they're waiting for beds. historically we haven't been an institution, and we don't to this day have within our walls inpatient psychiatric unit. And so these patients are going to general floors awaiting those beds in other institutions. And they are accounting for, at times, 41% of the inpatient admissions, while they are 16% of the general population. So, and then you're thinking about the inpatient side is a group of nurses who might not have that skill. There's so much resources sort of needed to take care of these families. And so really thinking about the impact of this population, they're about 10% of our inpatient volume and 4% of all of our patients. It's tremendous. So this is where Ruth comes in, because, while we're all trying to sort of build more infrastructure, really what we have to think about are the roots of these problems, right? And thinking about what, let's step back and think about where these kids are coming in from and what's going on. And that's when we get to thinking about our adverse childhood events and what is going on and what is shaping these patients' behavioral health crises. Certainly some of them are hardwired, by all means, yes. I mean, there's some of these that are not avoidable. But we know that adverse childhood events have an incredible impact on health and emotional wellness moving forward, and this is all part of it. And you can see this list of the yellow boxes. I mean, these are all things that are higher in our community as a result of the poverty and the violence. And you can see also, this is something that we know we need to attack. It's a crisis as any other lifelong disease, because it has severe impact throughout the lifespan of any population. And it goes on to lead to definitive early death. I mean, it is a risk factor for shortened lifespan. So we should address it as such. There's a lot of data looking at a variety of really interesting correlations between these events. And so thinking about how we take our environment and how do we attack it to try and really improve the lifelong health of our patients, but more acutely our behavioral health patients who are in crisis. So with that, I'm going to hand it over to Ruth. I think this is where it's so amazing that, Ruth is able to sort of translate this into work to actually not only sort of know and recognize that this is a crisis, but to really try and find ways to actually sort of ameliorate the problem at its root. So Ruth, thanks for being here. And again, thank you guys for having me. It's really great to be with you all.
Hi, everyone. Thank you so much, Rachel. Let me pull up my screen. So you should be able to see this now. Can you see my PowerPoint?
We can see it, you're just not in presenter. You are in like the presenter mode where we can see your notes.
Notes, okay. Let's try that again. Let's see. Here, I'm going to stop sharing. So the city is all about Teams, and so we use Teams rather than Zoom. And so often, I have to practice transitioning. Here we go. Better?
That's great.
Okay. Awesome. All right. Thank you so much again, Rachel, for that. There's so much intersection. We're going to actually talk about a couple of the same numbers, a couple of the same national numbers. So hopefully this kind of paints a picture of the intersection between these things. I'm not sure if most people on this call are Philly-based, Philia and Monco, Philly area. I'm going to be talking a lot about Philadelphia data, but I think that there's a lot that's translatable to other parts of the region. And I should also say that the kind of explosion of gun violence that we've seen in Philadelphia has been mirrored in basically every major city in the country. There's been a massive surge, and that's what this next slide demonstrates. So these are headlines from 2020. So as the pandemic hit, kind of extending into 2021. And what this shows is that concurrent with the pandemic, there was this massive surge in shootings. And this is both fatal and non-fatal injuries by firearm, some of which, depending on the region, were the highest in recorded history. And in fact, Philadelphia in 2021 hit the highest number of homicides in our recorded history. So we have seen this as a trend that is not limited to just our city. This headline is from Philadelphia. So this is from some of our colleagues over at Presbyterian, who said that in their ER in the midst of the pandemic, they were seeing more victims of gun violence than they were people with heart attacks, which is thought to be kind of bread and butter emergency medicine. And yet gun violence was emerging much more prominently. So this is where we are. And what I'm hoping to do with this kind of conversation, and I would like it to be a conversation, I would like there to be as much room as possible for kind of back and forth, is to convince you that this is a public health issue, convince you that there are reasons why we should consider this not dissimilar to a COVID pandemic, right? And that we should be using similar tools to address it and to address other issues like our mental health crises. And that while there's absolutely a role for criminal justice, that maybe that's not our first trick in kind of addressing this, and that there may be some lessons we can learn from the past to improve our response to this issue. So, and I'll start making that pitch with this, which I think kind of drives this home. So these are two maps of Philadelphia that show two issues, one of which is poverty and one of which is gun violence. So the map on the left is looking at the percent of individuals of all ages, children and adults, who are living in poverty, as defined by the federal definition for poverty. The map on the right is looking at both fatal and non-fatal shooting victims. And there's an unmistakable overlap in where you're seeing these two issues emerge, right? As far as where the darker blue are the higher density locations for both of these issues. And what you can appreciate is that you're seeing a lot of poverty where you're seeing a lot of shootings. We generated these maps for educational attainment. We generated these maps for employment, and they look very similar. This is looking at an intersection, just looking at men, because in Philadelphia, the vast majority of people who are victims of firearm violence, fatal and non-fatal, are young Black men. So this is looking at men who are shooting victims and men who have unemployment, what's called chronic unemployment, which means no employment within the past 12 months. And what you can see is that the orange parts of the map, the orange zip codes, both things are high. You have high numbers of shooting victims, and you have high numbers of men who are not employed in the past 12 months. And the areas that are boldly outlined in Black are predominantly African-American, and the areas that are outlined in white are predominantly Hispanic. So this map tells you kind of a lot of things in one map. It tells you that in the same areas that we already said had a lot of shootings, there's a lot of unemployment in the group of people that are most being affected by the shootings, right? The people who are being victimized, this is a core need. Employment is a core need that's not being met. And that these zip codes are overwhelmingly Hispanic or African-American, predominantly African-American actually neighborhoods. So lots and lots of data with lots and lots of historical context that we could talk about that emerges from this. And this is kind of where I believe our solutions to fixing this violence need to start, right? So we could say, here is a person who has brandished a weapon or done something with a gun or has been found carrying a gun. And we could use incarceration as our primary tool. And no mistake, if someone breaks the law, there's punishment for that. We understand that. But why do we keep on getting from the same communities a recurrent trend by which people are coming out of these communities and enmeshed in violence? How do we go all the way back upstream to talk about why that trend is happening in the first place? And could that actually give us better results in preventing violence going forward? So this is just a little bit more context. We have newer data now. We have the rest of 2021. Some of the good news is that 2021, the numbers actually evened out a little bit, but remained higher than 2020. And then we're starting to collate data for 2022 as well. But each year has been a little bit worse. And so I will tell you that 2022 has already started out worse than 2021 was. So we are on track to have more homicides unless we are able to find solutions that actually make a difference. There's a lot of variation by a number of metrics by time of year. So the monthly numbers are across the top on the right there by who is affected. But it's really striking. I really want to draw your attention to the graph on the bottom right. And that's what I already said, but it's really just so impressive to see in a graph how non-Hispanic Black individuals are way up there as far as the percent of shooting victims of the yearly total. And everyone else is kind of clustered in that less than 25 range. It's incredible, right? How much disparity there is in this particular public health issue. So there's a great deal of urgency, and in this era in which we are all acknowledging the need for racial justice now, in the midst of Black History Month, it's never been more timely to identify that something clearly needs to be done at the root of this problem. I won't belabor this point, but this just emphasizes again how visually it's really impressive how overwhelmingly this is affecting certain members of our communities. So when it comes to our life in the emergency department, we definitely see this manifesting, right? So each year you see the numbers go up, and by and large, you also see ER visits go up to match that, as makes sense. It's fairly uncommon to sustain a firearm-related injury and not have to come to an emergency room. So what happened in 2020 as the pandemic occurred and as the numbers of shooting victims surged, there was this really strange tension of resources, primarily with our adult colleagues, where they were trying to manage patients who had critical needs related to COVID and trying to manage patients with critical needs related to gun violence, and patients who had both, right? And needing to kind of balance the need for resources in both of those settings. And there was a concern that patients who are coming in for other reasons like gun violence would have worse outcomes because the hospitals were so strained. If that doesn't make the case that this is a health issue that affects health systems and health providers, I don't know what else would. It's very clear. And I think that the experience of emergency providers in the midst of the pandemic emphasized that we can't ignore the health implications of gun violence. This is what it looks like when they come in with the initial injury. But of course, those who survive their injuries, and the number of people who are non-fatally injured is 4 times the number that are fatally injured. So all of those survivors, that's when we see them potentially coming in with exacerbations of mental health needs, with chronic physical complaints, and a myriad of other things. And so it doesn't end here. And that's why I think the preventative approach is so critical to focus on. This is looking at a kind of newly emerging trend, just to kind of parse out pieces of the population that are affected. And this is a collaborative of women. So I think this is an appropriate kind of forum to talk about this. Unfortunately, what we're seeing is that, this is an overwhelmingly non-Hispanic Black male epidemic. That's at some of the highest levels that we've ever seen. But there are other facets of the population that are nowhere near untouched. And so this is looking at women 18 and older who have been shooting victims in Philadelphia over the past few years. And you can see that those numbers have also been rising every year. So 2021 had, far and above the prior years as far as numbers of women. This is a running total. And 2022 has continued to see this trend, so much so that there's been a specific emphasis on domestic violence related shooting incidents and how much that's been kind of driving these numbers among women. Similarly, we're pediatricians, and so we're very focused on those who are less than 18. And we definitely have seen, and I have gotten many, many emails from people saying we are seeing more shooting victims. Our numbers are not as impressive as when you look at the whole city, right? It's a significant problem for those predominantly who are older. The majority of shooting victims are more in their 20s to 30s. But we're not seeing an insignificant number who are young, and they carry the effects of these injuries for their entire life, assuming that they survive. So this is an incredible problem. You can also imagine how this influences carrying behavior. So if you're 14 years old and you've already been victimized by gun violence at that age, how are you going to make decisions about whether or not you carry a gun in your day-to-day life, and whether or not that ends up attracting additional violence? We know that the presence of a gun in what would otherwise be a straightforward altercation escalates the lethality of that altercation by a lot. Now we have a lot of young people who feel that they need to carry guns. And then overlying that is the very real fact that firearms have flooded into our city in the last 2 years. So when the pandemic hit, the statewide instant background check system actually crashed because there were so many requests for background checks as people purchased more firearms, as the world seemed unstable. The shelves were cleared of kind of durable goods. No one was sure what was coming. And one of the responses to that, interestingly, was a large purchase of firearms. We fully expect, just based on past precedent, some of those firearms to filter onto the streets in urban environments like Philadelphia. So we know that there's an infusion of guns that's going to be kind of a slow infusion, right? There was an infusion of guns that happened right then, and then that continues to go on as those guns kind of enter the black market. And so when young people feel unsafe, they feel the need to be armed. There are plenty of weapons for them to be armed, and they are traumatized. That's kind of a lethal combination, and that's what we're operating with right now. So this is where this kind of ties into what Rachel was talking about. During the pandemic, we know that mental health related ED visits went up nationwide, despite the fact that overall ED violence or overall ED volumes in pediatric hospitals absolutely dropped throughout the whole country. But how many of those visits were for mental health complaints? That's what went up. We also know that living near a shooting incident is associated with an increase in having visits for mental health related causes. And this research for children and adults was actually done right here in Philadelphia. And then finally, we know that exposure to firearm injury is linked to post-traumatic stress symptoms and future injury. It's also linked, as we know from ACEs, to other completely unrelated or seemingly unrelated health outcomes. So the original ACEs didn't look at exposure to violence as one of the primary adverse childhood experiences. What was called the expanded ACEs had the foresight to recognize, wait a minute, there are all these kids who live in urban environments, and they may have some of the traditional ACEs that were outlined in the initial studies, but there are all these other adverse experiences that weren't even measured initially. And so there's been additional work to expand what we know are adverse childhood experiences, and exposure to violence in your neighborhood absolutely is one. We also know that even just seeing and hearing evidence of violence can lead to trauma. So there's the trauma of being personally shot or shot at, having someone in your family injured or killed. But there's also the trauma of getting ready to go to school and seeing bullet casings on your sidewalk on the way there. There's the trauma of, and this is a Philadelphia problem that needs to be solved, that there's no one whose job it is to clean up a crime scene when someone has been victimized. And so community members and family members do crime scene cleanup in our city. That's traumatizing, right? Even if you don't know the person that was affected. So we know that if we just heard or saw evidence of gun violence in our neighborhoods, we would be traumatized. That is compounded, I think, when you see it recurrently, and that is compounded when you are a child. This is kind of driving home this point of exposure to violence, peripheral exposure to violence, because this is a really important point. We often focus on those who are directly affected because we can find them and we can measure them. But what about the people who go to school or rec centers or parks in the areas where this happened? There's not a way to identify those people other than by place, but that's traumatizing in and of itself. And so on the left is a map, same maps that we saw before, Philadelphia zip codes, but looking at individuals who were shot within one city block of schools, rec centers, or parks. And on the right is another measure from the Household Health Survey, looking at people who say, I don't have a safe place to go to outside. And so you can see that there's some overlap here, right? City residents are less likely to report safe access to a park or an outdoor space in places where we know that there aren't a lot of shootings, right? And this makes sense. This is a little bit intuitive that saying there's no safe space makes sense. In addition, again, from studies that we have done right here in Philadelphia at Penn, people know that the presence of green space reduces violence, and that greening blighted lots and vacant lots actually measurably reduces firearm violence in particular. So people don't have access to green space, they don't go outside, and that results in a number of negative health outcomes. So my program is housed within chronic disease and injury prevention. So nutrition, physical activity, tobacco, and smoke-free Philadelphia, all of those are within the same division. You can imagine a lot of overlap here. We also see a lot of obesity in the city of Philadelphia, and that is often in places where there's no safe access to parks or outdoor spaces. So now you can see how all of these public health issues are actually feeding on one another. And what you get is a city that is profoundly unhealthy and is kind of starting, and children, I'm going to say children because I'm a pediatrician, but individuals, so I think it extends to adults as well, who are starting from behind. And so if we're looking for holistic health for the city of Philadelphia, we need to look at how all these problems are intersecting. So I love this framework. I talk about it all the time. This is how we need to reorient ourselves around addressing health and really eliminating health inequities. And this is from the Bay Area. Ultimately, often we as physicians are focused on the disease and injury. And we may sometimes have conversations with people about risk behavior. So that's all the stuff on the right, right? So we see someone with a medical condition, let's say asthma, and we treat the medical condition at that moment where it says healthcare. And maybe we'll say things like, oh, smokers and pets and other things in the home that might trigger your asthma, and talk a little bit about the individual risk behaviors that someone might have. But at what point do we recognize that it's also our job to think about the fact that everyone who lives in these particular houses seems to have a lot of exposure to asthma exacerbations, or that smoking is more prevalent in sections of the city, parts of the city, where we're seeing a lot of kids coming in with asthma exacerbations. And that in fact, when you really start to go downstream, we realize that tobacco outlets have intentionally targeted poorer parts of the city and have facilitated increased use of tobacco in those communities. And that's where you really start to go upstream further and further and further. And then you deal with the core problem. How do we deal with the inequities in distribution of resources? places where there are food deserts, but there are 15 tobacco outlets in that same zip code? And how do we address why that's true? And how do we develop policy to make that not true? And how do we then see decreased asthma visits because we went upstream far enough to really deal with the core issue? That's the vision, right? So health has I think medical practitioners have realized this, like, gosh, we're just going to keep on treating your asthma. At what point do we go and fix the house? And so CHOP actually has a program where they will go into the house of someone who has very frequent asthma visits, and they'll deal with the pest control issues, and they'll provide tobacco cessation materials, and they'll actually gut the house in places where it's necessary, remove the carpet, for example. They'll do things to mitigate the risk of asthma so that patient doesn't keep on coming through the ER. That's what we should be doing, rather than just, we keep sending you to the ICU with your asthma exacerbation and we're not fixing the core problem. The same approach is needed for gun violence, right? We need to think about, like, we keep seeing you injured, sometimes before even gun violence, we're seeing assault, we're seeing non-firearm related injuries. We keep on seeing you in our ER for these things that are a symptom of larger structural problems. How do we then move upstream and deal with those larger structural problems so we don't see you in the ER in the first place? I always joke that police and physicians are the two people who should be out of a job if the world was as it should be. And so the idea here is to kind of reduce how much we're just pulling people out of the river one by one and not fixing the broken bridge upstream. So this is what I've been tasked with in the city, is developing a public health framework for fighting firearm violence. And we've oriented around this table, which is something called a Haddon's matrix. And the idea behind this is you're looking at all the factors that drive the problem before, during, and after a shooting event, from the host or human individual level all the way to the social level. And when you plug in all of your interventions into this framework, you can see where you have enough, where you don't have enough, and how you can maybe innovate a little bit to address any issue from a public health framework. And we try to focus all of our efforts as much as possible in that kind of pre-event space. So I'm going to pause. These are our injury prevention work areas, and I'm happy to talk about any of them. I told Rachel before this that I can kind of talk about this topic for a long time. So I'm going to pause and kind of open it up for conversation, and then we can dive into our additional work areas as we have time, because I'm sure there are questions, and I wanted to be sure that we have room to talk about them.
Hi, this is Keith. Thank you so much. You two are very impressive, and I could ask you a dozen questions very easily. But one of the things that you said piqued my interest, particularly when you said that CHOP will actually go into a home if you've had repeat visits for asthma, for instance, and go all the way to maybe taking the home down. How is that paid for? Who takes care of the cost of that sort of intervention?
So the name of this program, I want to say it's the CAP program, and I'll try to find a link to it and put it in the chat if I can. I'm
with Habitat for Humanity, and so yes, we're one of the contractors that works with the CAP program, and Dr. Bryant.
Bryant.
So yes. So that's why I was like, both throwing you hearts and what have you. So I'm Corinne O'Connell. Nice to meet you all. I'm blown away, amazed, in awe, and you must be exhausted. And yeah, so what I would add is, one, we are, in some initial pilot work with you all on the asthma prevention program and that upstream methodology that you're working at. And two, the study you referred to, the Eugenia South study, that even one home repaired on a block, the surrounding crime goes down 18 to 20%. So that's where we come at it from a habitat side of things, with 121,000 homes that are falling down, owner-occupied homes that are falling down. That housing has got to be a strategy as we look at gun violence as a public health crisis. So I'll be quiet. I'm also, you guys, you can appreciate this as inspirational when I'm multitasking on my way to the dentist. So I am here, I am listening. But if I pop back onto a video or come off video, you guys don't need to see me at the dentist.
Thank you for that.
Corinne, glad to have you with us. Thanks, Rachel and Ruth. You're making such a compelling argument. This is Chris, by the way. I, of course, I think we assume, those of us who in education assume that there's a huge correlation here, but I didn't see education come up in your data. And so I wonder how much research has been done correlating directly education, quality, graduating from high school, et cetera, with all the gun violence and all these other social problems we have. So that's my question.
It's a great question. So usually I'm a good multitasker, but I don't want to switch screens too much. So on our injury prevention dashboard, which I'm happy to put the link to in the chat, there are a number of buttons that look at the overlay between violence and X. And so poverty is the one that I showed you, but educational attainment is another one that's on there. And so and then there's a final category that's of particular interest, which is something called opportunity youth. And we're actually revamping that map. So it will be new as of hopefully Friday. But opportunity youth are individuals between 16 and 24 years of age who are neither in school nor employed. And this is a category that is a priority to the city for obvious reasons, right? That is at or just before most people end up victimized by firearm violence. And we already discussed the fact that not being in school and not working are at least correlated with, right, if not causal of, gun violence. And so having this key group of individuals with nothing to do is an obvious problem. And so I would argue, being somewhat simple-minded, that giving people something to do in that age group seems like a preventative strategy, right? So how do we concentrate available resources for education and employment and individuals who live in high violence areas and don't currently have access to those things? And the other thing, and I'm curious actually what those of you who are educators would say about this, is that one of the things that sometimes happens is that someone goes all the way through school and then they're 16 or 17 and they drop out of high school, or they're at risk of dropping out of high school. And then we say, we really got to give this person education because we think that's preventative. But, maybe it's because I'm a pediatrician, maybe again, it's because my mind works very simply. You kind of can't jump in the deep end like that, right? If we really wanted that person to have a high likelihood of being in college at that age, which is what we would hope for them, or having gainful employment, we probably should have thought of that at pre-K and in elementary school and throughout the kind of educational journey that they were taking. If we were not meeting their educational needs or providing them with any kind of visioning for their future or giving them workable skills, if they are graduating from school or even entering high school and not really competent in reading, then it's a little bit tough to then say we are going to provide resources to connect these people to education. So what often ends up happening is people are connected to things that they are not able to thrive at, which kind of decreases their faith in the system, or people are given very limited opportunities, right? There's some specific job trainings that you can do, but it's not, the world is not it feels to them that the world is no longer their oyster because we kind of failed them for 12 years preceding that moment. So I think all of that to say, and I'm curious what educators think, I think it's a little late to prioritize someone's education at 16. I think that if we really think education is one of our silver bullets, no pun intended, we should probably be investing very early in the quality of education available to individuals who live in high violence neighborhoods. And that's another place where it can be hard to direct people's focus, but I think that there's a case for that. I'm going to assume that all the educators agree with me. Take that and run with it.
So Ruth, I was actually looking for like a hand to raise, and I'm not used to Zoom. So this is Allie Goodner. And so I actually just had a question about this. So yes, no, do agree with you. Agree with like the early intervention piece that you're talking about. I'm curious how CHOP partners around that too. So I know that, we've had some, pre-K for PA initiatives and a lot of work that's been done in the city over the years. But I'm curious to know like how CHOP does or is limited in like advocating for those sorts of things, or even being part of like fundraising for, I don't even know if that's part of it. Like, is there like a funding relationship in that as well? Just knowing that CHOP does have resources around that. So I'd love to hear. So yes, agree. And then two, just what are the conversations that the CHOP, and this might not be in yours and Rachel's area, but I don't even know the CHOP Foundation, or I'm just curious what those conversations have been, if any.
It's a great question. I'm curious, Rachel, if you know more. I don't know very much about CHOP's involvement specifically. I do know that my understanding is that the foundation of Penn Alexander was meant to be, to some degree, an acknowledgement of what was happening, right in our backyard, basically, as it pertained to education. And that ended interestingly, right? Because I think, it's great that that school is there, but what ended up happening is, and I think these were unintended consequences. It drove up the cost of living and the availability of housing in that area, and generated kind of more micro environment disparities where there were macro environment disparities. Again, completely unintentionally. I think there were lots of positive consequences too, but I think that there are a lot of people who ended up kind of priced out of that engagement. So the question is, how do you improve the quality of the education without pricing people out of the neighborhoods where the education is good, right? And that's a really tough balance to strike. I will not pretend I know the answer to that. I think that there have been some other like direct donations and conversations around education, but I don't know what they were. So I want to give CHOP credit potentially for having conversations that I just don't know about. But that's as much as I know.
Yeah, I'll just echo. I think currently it's quite piecemeal. There really has. Penn has done some, but as an institution, CHOP has not really been in the education game per se. Even though it is such clearly, as we all would agree, a clear social determinant of health. They, I think, do occasionally have a hand in some of the interventions that come out of the sort of on the Penn side, School of Education and those sorts of things. But in terms of the sort of CHOP, particularly the primary care network, right? Who, there's the big house, and then there's the primary care networks that are all over the city and all over the counties. And they're really the groups that would really know the local environments the best, the nuances of the various public elementary schools the best. They have not been equipped with adequate resources to be able to do sort of beyond their walls as of yet. So they don't have hands in the public schools. There are other cities where the relationship is quite different, where the relationship, even let's say between school-based nurses and the primary children's hospital in the city is quite close, and they actually have more of a network that has not been the nature of the CHOP relationship historically. So there are some one-offs, there's some occasional really nice relationships that have been present and developed, but it's not a uniform infrastructure where there's a good safety net or web where CHOP sort of has their hands in the Philly public school system by any means.
Ruth, there are many educators on this call, and in response, Ruth, to the issues that you raise, I think everyone certainly agrees that it's grades 3 and 4 that really set the tone for achievement moving on. Reading, writing, thinking. And I know Mary's very familiar with Children's Literacy Initiative, who provides coaches to teachers in the inner city schools to teach best practices in literacy, which, I think the more focus that is on that, the more you're going to avoid the 16-year-olds who are dropping out of school. Hopefully, that's the idea. So I'm interested to hear other people in education's thoughts too. And I'm also very glad to hear what Penn is doing generally for some elementary school work in their area. So.
Yeah.
Thank you. This has been great for, I think both Rachel and Ruth, thank you. This has been really fascinating. I'm curious to know if you can tell us a little bit about progress that's been made. I guess one area that I would be interested in knowing more about is the money that has poured, I guess it's very recently, but into a whole variety of violence prevention initiatives in Philadelphia.
Sure.
But also more generally, just what is there reason to think that some of these initiatives are starting to be successful? Is there a bright spot on the horizon?
Yeah, sure. So this is a good segue into kind of our work areas. And I think that what I was hoping to do with this is talk about where people might get plugged in if they're interested as well. So I'll start by talking about the Roadmap for Safer Communities, which is PRSC. And so, as I had said before, we are responsible, my program is responsible for the public health framework of that. And it's the roadmap and the Criminal Justice Public Safety Office in the Managing Director's Office that has run 2 grant programs. One of them is called TSIG, to Targeted Community Investment Grants. The other is called CEG, which is Community Expansion Grants. All of these are grants for organizations that do work that plausibly reduces gun violence or addresses gun violence. One of them is smaller order, 30 to 50,000. The other is up to $1 million in grant funding for kind of larger organizations that are more established. And this is based on some work that was done by a researcher named Patrick Sharkey that found that just the number of community organizations meeting needs in local communities is correlated with a reduction in violence, like not even related to what they do. Just like if you have 50 versus 100, we see less violence kind of as a pure metric. And so the idea is, let's do that, let's increase the number, but then let's also kind of choose ones that have a targeted approach around gun violence. And then let's do something that we haven't always done super well as a city, which is measure the impact of those investments. So the CEG grant cycle finished kind of in the fall, and then a bunch of organizations got onboarded, selected and onboarded in the later part of last year, and they're all getting started now, kind of as we speak, all of their work. And there's a wide variety of services they provide for reentering citizens, after school programs. There's a variety of things that they do. And then all of them are being provided with technical assistance. And so there's a specific organization, the Scattergood Foundation, actually, which is tasked with providing them with technical assistance around service provision. So how do you keep better records? How do you develop a model for what you're doing so that you can measure its impact in the future? How do you do better bookkeeping? Like all that kind of thing to kind of improve the functioning of these organizations. And then they also get evaluation assistance. So there's another kind of body that's entirely tasked with helping to measure the impact, or probably not the impact realistically, but more just the process. And so how well are they doing at recruiting the clients that they say that they want to recruit? Are they actually capturing those individuals? That kind of thing. So that's a CEG program. So it's a large amount of funding. And so that is a reason, I think, to hope, because there may be some innovative solutions that are on the ground that we are going to learn about through this grant program. There are a lot of things that have come out of Philadelphia that are kind of gun violence reduction strategies that have now gained kind of national and international acclaim. So everyone talks about greening. Some of the original work on that was done by Charlie Browness and Gina South at Penn. And their work is still, I think, some of the foundational literature for that. So Philadelphia is the home for a lot of really good ideas around reducing violence. And so if we can find people who have been churning out those ideas in their block for years, but never really had the funding to expand, study, and improve what they do, the idea is that these grants would help them do that. And then again, the TSIG grants, the smaller ones, are just to provide people with a little bit of assistance. If you just have like 10 high-risk kids that you're mentoring on your own dime, the city should support you. So the goal is to kind of engage with smaller shops on that. So I do think that's a reason to hope, absolutely. I think another thing that's a reason to hope is, many of you may be familiar with all the politics of Philadelphia and some of the drama that results from that. Sometimes law enforcement agencies aren't everyone's biggest fans, and this person doesn't like the mayor and this person, whatever. Ultimately, there have been places where there have been collaborative efforts between all of these parties. And that is, I think, a massive reason to hope, because all of these different bodies hold a different part of the solution, and affect a different part of the problem, right? A lot of the people who are engaged in violence on either side of the gun have gone through the criminal justice system. So anytime that those individuals are working together, it's a bright spot. And there are a couple of places on the city's roadmap for safer communities, in this organization called Purpose, which I have on the screen, the Philadelphia Interagency Research and Public Safety Collaborative. It's a mouthful, but what it basically means is that the health department, the DA, the defender's office, the police, the comptroller's office are all playing nice together. And that's a really big deal, and something that hasn't actually happened in a lot of forums before, or other times that we've been fighting gun violence before. So that's I think, another reason to hope. And then there are other, I think, initiatives that we are hoping will make a difference. So the CHOP has one of two kind of certified hospital-based violence intervention programs in Philadelphia. There are other hospital-based programs that aren't part of the formal HVIP network, but they still do the same thing. What these programs do is, if someone is violently injured, usually in the hospital or soon after, those people are engaged. There's a conversation about what they've gone through and what their needs are likely to be. And then they're followed with longitudinal case management resources for sometimes years after that initial injury, often for months. And they get a myriad of things. They get everything from support and help navigating the criminal justice system, support navigating the school system if they're still in school, trips and support going back and forth to their medical visits, mental health support and resources, family counseling, et cetera. Someone will sometimes go with them to their arraignments. And I mean, there's a lot of support depending on what people need. We have formed a collaborative of all of these programs that includes all of the level 1 trauma centers in Philadelphia County, all 6. And so the idea is, if all of these programs get together, we can share best practices, we can follow collective outcomes, we can identify where there are holes, where there are people who are actually being violently injured and not getting connected, and why, and how can we kind of mitigate that. We can talk about how to expand what people get out of this. And so it's great to give people access to mental health supports, but honestly, if you're hungry or if your heat is off, it's really hard to focus on your mental health. So how do we meet basic and core needs as part of this model so that people actually are receptive to, or have the capacity for, some of the higher order needs that they may need to have met? And then so we launched that collaborative, and then soon after we are also doing a cure violence model of this. So same idea, there are different people in the city doing cure violence, which is a violence interruption street model for fighting violence, but they don't all work together. How do we get them all in the same room under the health department's umbrella, share best practices, improve practice, measure outcomes collectively, et cetera? So we're hopeful that that's another reason to hope. Right now, people are recruited from the hospital setting, but there's no reason they can't be recruited from elsewhere. This is sad, and again, very relevant to the fact that there are educators on the call, but the CHOP Violence Intervention Program, when it looks at where most people sustain their violent injury, and this isn't just firearm injuries, this is violent injury, including just assault and other things like that, most of them are in school. Most of them, it's in the schoolyard, it's right after school, it's at recess, it's around school. That's where a lot of these kind of beefs manifest, and then they kind of follow people home. So that's a problem, right? Because that's not really what school is about. And we're recruiting those patients after they've been injured and come to the ER, but lots of kids get in fights in school and don't come to the ER. So do we take this model to the schools? That's one idea that we're exploring, so that we can kind of go where the problem is, at least for pediatric patients. Is there any reason we can't recruit people who are being released from incarceration? Because if your injury was 2 months ago, a year ago, your needs are likely the same, right? You continue to need mental health supports, case management, basic life support of various kinds. So if someone is emerging from incarceration, has unresolved trauma, and maybe even unresolved physical issues resulting from their prior firearm injury or assault, maybe we capture them then if we didn't get them once they were when they were in the hospital setting. So that's one of the things that we're exploring, and I think those are all ways to take, you know, a resource that's kind of catching a minority of eligible people and optimize it so that it's actually capturing ideally a majority of eligible people. So I'll stop there again. Talk a lot.
This is Chris. One last question before we say thank you, And we'll say thank you before that last question. But what can we as as lay people do to help in this regard? Are there resources that we can find and share with people? How can we help? These programs are so severe. The outcomes are so difficult. And so any reflections or answers or resources, even if you send them out later, we'd be happy to circulate them.
Yes, that's perfect. So yeah, absolutely. I was going to propose that. So I'm happy to send out a number of resources that might be that may be easy to kind of disseminate and particularly relevant. And then also some coalitions that people might be interested in joining, including many that you've heard of, like Moms in Every Town, et cetera, who do really good work locally as well. So I can definitely send that.
A number of the, the chat messages, I don't know what happened to my voice, sorry, are saying thank you, thank you, thank you so much for sharing your expertise. And a terrific program today. We thank you, Rachel and Ruth, so very much for calling to our attention these great needs. And any way groups like ours or individuals can help get out the word about the needs and what people can do, please share. We're grateful. Thank you so very much.
Thanks for having us.
Thank you.
Thank you so much.
Thank you.
Thanks, Ruth.
Bye.
Thank you. Thank
Thanks,
you.
guys.
Bye.
Thanks, Chris.
Thank
Bye.
you. Look who's here.
Hi, Kath.
Hi, Rach. This was a really good program. Thank you so much.
Good to see you. Miss you.
Good to see you too.
See you guys soon.
Hi, Allie. This was awesome. You guys were great. Ruth, this was fascinating. Thank you so much for including me.
So
Bye,
glad
everybody.
you're here, Kath.
Thanks.